Assalamu alaikum everyone and welcome to ECREM Talks, a podcast where we discuss emergency medicine core concepts and the impact of the specialty in the UAE. I'm your host, Dr. Shaikha Alahjeri, and today we're excited to bring you our very first oral board case in podcast form. We want to try out this new format where we do an oral board case examining a resident who is not aware of the case ahead of time. You'll see them go through it in real time and have the chance to think along with them. After the case, we're going to debrief and briefly discuss learning points for the final diagnosis of the case. We feel this may be a more engaging way to learn about the topics discussed, but please do give us feedback through our comments or on our email in the show notes. Today's resident participant is Dr. Soniya Shivnani. She's a PGY2 from SSMC with an interest in teaching and is a core member of ECREM, holding responsibility for the podcast. Testing her today, we have Dr. Maitha Al Matrooshi, a newly graduated emergency medicine specialist with an interest in teaching and critical care medicine. Now, without further ado, let's get on with the case.
Hi, I'm Dr. Maitha. I'm an ER specialist, and I have with me Dr. Soniya. She's a R2 emergency resident. She's not a junior, not a senior yet. She's in between. Okay. We will have a case, an oral case as a practice. We'll give you 15 minutes. We'll go through the case. You can ask me any question. You can ask me about anything, any details about the case, and I'll show you anything related to that. Okay. And then we will discuss the case as management-wise, the approach was correct, and what are the key learning points and the pitfalls. All right, Sonia?
Yeah, to be precise, I have 3 months. I'm still
remaining, yeah. So she's still an R2 technically.
Yes.
She has still 3 months to consider herself as a
no
R3.
high expectations.
No, we'll have high expectations from you today. Okay, all jokes aside, okay? All right, are you ready, Sonia?
Yes.
Okay, all right. So your chief complaint is a 25-year-old female with abdominal pain and vaginal bleeding.
Okay, so where is this patient?
The patient, they just entered her to the zone.
Okay.
They assigned her to a bed.
In the zone?
Yeah.
Okay, which is low acuity area.
They just placed her there.
Okay, so now when I'm entering the room, what do I see? How's the patient?
Okay. So the patient appears stated age, scared, uncomfortable due to pain, lying still, supine in the stretcher.
Okay, I have nurses with me.
Your nurse is there.
Okay.
What do you want from her?
So I'll ask her to connect her to the monitor and get me the first set of vitals. By that time, I will speak to my patient.
Okay, so the nurse, she's connecting her now to the monitor. So you get the heart rate is 96. She's afebrile.
Okay.
Temperature 37. So her saturation is 100% on room air. And the recorded blood pressure is 95/63. And RR 12.
Okay. Hi, how are you? So, I'm
Okay,
Dr. Sonia. I'll be taking care of you today.
Okay.
Could you tell me what happened?
Okay, so basically, I have started to have abdominal pain and vaginal bleeding since this morning.
Okay.
Okay.
Are you married?
So, yes, I'm married.
If you don't mind me asking you, when was your last period?
It was 1 month ago.
Okay. Any specific date if you remember?
I don't remember exactly the date, but it's 1 month ago.
Okay. Do you know that?
But less likely, doctor, to be pregnant. I had tubal ligation done 2 years ago.
Okay. Any specific reason for that?
No, I just don't want kids anymore.
You have kids from before?
Yes, I have 2 kids.
2 kids, all normal vaginal delivery, any complications?
Yes. No, normal vaginal delivery.
Okay. But you are sexually active?
Yes, I am sexually active with my husband.
Yeah. Okay. Any other type of contraceptive you take?
No.
No. Okay.
Since I did the tubal ligation, they told me no need.
Okay, that's all. So
that's
nothing
all.
else.
Yeah.
Okay. I'm gonna ask the nurse to put 18 gauge cannula by this time.
Okay.
Get me basic labs like a CBC, a UNE, a preg
The
test.
charge nurse comes to you
Okay.
and tells you, doctor, I am concerned. The patient looks hypertensive.
Yeah.
Do you want to keep her in the zone or shall we shift her to the resuscitation room?
we will shift her to the resuscitation room. That's what I'm going to tell my charge nurse. When we are shifting, I want 1 liter of normal saline to be placed while we are shifting. Get me the labs what I've asked, which will be CBC, UNE, a preg test, coagulation. And so once the patient has been shifted, I will do an examination on the patient. Okay. To begin with, general examination, does she look pale and how is she? I know you mentioned before she's scared looking, but is my talking helping?
Okay, so just to clarify, you want detailed examination?
Yeah.
So tell me, what are you looking exactly for?
So vitals, is any change in the vitals to begin with?
So you just started her the fluid, right?
Yeah.
So let's wait until we complete the fluids.
Okay.
And we'll reassess after that.
Okay. Yeah.
So generally, she's alert, oriented. Okay. And she's in pain, in moderate distress due to the pain. And she's still nervous while talking to you.
Has she taken any painkillers at home?
No, she did not.
So we will give her a paracetamol IV, 1 gram.
Okay.
And any past medical history she has?
So,
other than this tubal ligation?
Past medical history?
Yeah.
No, only the 2 pregnancies and as I told you.
2 pregnancies and the tubal ligation. Okay.
So you were asking me about the
examination. Since she doesn't have past medical history, ketorolac 30 mg IV, something I will consider for analgesia as well. Okay. Generally now on chest.
Okay.
Auscultation examination.
Auscultation, the chest is clear. Bilateral air entry, it's equal.
Okay. Pulses bilaterally.
So she's a bit tachycardic. Okay. Pounding pulses. Capri fell less than 2 seconds. Okay.
Yeah. And auscultation of the heart, any murmurs?
No murmur.
Okay, abdominal examination now.
What do you want to know?
So, to begin with, inspection.
Okay.
Anything, any scars?
Only like the laparoscopic, because she had tubal ligation.
Yeah.
Okay.
Yeah.
And what do you want to know also?
Then on palpation, is she tender anywhere? I'm doing the all 9.
Okay, so her abdomen is soft. Okay. She has tenderness in the hypogastrium area.
Okay.
There's some voluntary guarding.
Okay.
There is no rebound or rigidity.
Okay, and the temperature on the skin?
That's it's a normal temperature.
Normal temperature. Yeah. Okay. I will also do vaginal examination. Okay. So
what are you looking for?
She's bleeding.
Yes.
Is the bleeding internally? I mean, it's like...
So she has blood in the vaginal vault.
Blood in the... Any clots?
No clots.
Any retained product of contraception? I mean, you can guess how nervous I am. Retained products of conception.
There is no retained product in the vaginal vault. There is only bleeding.
Oh, okay.
Okay.
I love my ultrasound with me, so I'm gonna take that with me. Put a probe.
Okay.
And see what do I see.
Okay. So where exactly? What do you want to see?
So
what are you trying to look at?
So I start with suprapubic.
Okay. Just sorry to interrupt you, Sonia.
No problem.
So meanwhile, after 1 liter of normal saline, the blood pressure now is 105. 105 basically over 70. Heart rate 85. Respiratory rate 12. Saturation 100% on room air. Okay.
She's improving, so I'm happy at the moment.
Okay.
And also I'll get a critical panel blood gas on her with my labs and an ECG.
All right. So the patient is very anxious and she's telling you, I'm still anxious. Why I'm bleeding? Why do I have the abdominal pain?
Yeah.
And I'll show you your ultrasound.
I'll go obviously suprapubic, Morrison.
Okay.
Explain.
Do you see?
This is where? Where
suprapubic.
Suprapubic.
Yes.
No video.
No video. I can adjust the brightness for you to see better.
I've asked for beta HCG.
Okay, it will come.
The quantitative, yeah. I don't know what is this.
Try to find the anatomical landmark. So this is suprapubic. What are you looking for in ultrasound?
I'm looking for a uterus.
Okay.
To be honest, to see if there's anything. And also, those molar pregnancies and...
Okay.
If any...
What is your main concern in this patient right now?
To begin with, I know there cannot be a possibility. However, I really think that she's ectopically... she's gotten pregnant and the embryo is ectopically planted somewhere and she's bleeding from that. That's my main concern.
All right. So you're thinking of ectopic pregnancy, right?
Yeah, I am. Yeah.
Okay. So, you don't know what this image view is. I'll show you another different view. Do you want any other view?
Yes, I do. I told her I'm gonna do.
So I gave her a clue, maybe. That's my mistake.
I said from before.
Okay. Before I show you this.
Okay.
The patient is in shock, right?
Patient is in shock. Okay.
So we were not considering shock as a differentiate?
I was, because she's bleeding and she was tachycardic and hypotensive. That's why I started fluids.
So the patient, her shock index is positive, right?
Yes, shock index is positive.
What do you do in undifferentiated shock?
You do rush protocol.
Rush protocol.
Yes.
Hello. Okay. What do you look at?
You start from the lungs to aorta.
Okay.
Abdominal, the E first, and also DVT. Okay.
So you are basically trying to find the reason of the shock.
Exactly.
Whether it is a volume issue, if it's a
IVC you check as well.
Right? The pump, the tank, and the pipes, right?
Yes, exactly.
That's the main idea of doing rush protocol.
Yeah.
Okay. So in this case, what do you think is the cause of her shock?
Hypovolemic. Hemorrhagic.
Or hypovolemic. Okay.
Yeah.
So what are you looking when you will do the rush? What are the main things you will focus on?
I will focus on...
Okay. So you have 5 minutes, Soniya.
Yeah.
Okay.
Okay. I'm gonna check the pump, which is the heart. Obviously the contractility. I'm gonna check the pipes. So which will be obviously the IVC and the aorta. And I'm gonna check the abdomen, because I need to know where it's collecting.
Okay. All right.
Yeah.
So you got this view now. What is this? Can you explain?
Yeah. So there
Describe
is
by me.
hypoechoic line between the liver and the kidney.
So
Morrison's pouch.
Morrison's pouch.
Yes.
Right.
Yeah.
So there's fluid in Morrison's pouch.
pouch.
Okay. What would you do now?
Start another liter on the patient for fluid. Also,
the nurse is concerned. And she comes and tells you, doctor, patient is still hypotensive. Do you want to give her fluids?
And I want to prepare for blood as well.
Okay.
Yeah, and because I sent coagulation in the beginning, I'll add like a type and cross. However, because I'm suspecting the pregnancy, I'll start O negative.
O negative.
Yes.
Okay. So the nurse will tell you, okay, I'll get the O negative now for you.
Yeah. Any labs have come out. And I've started the second liter and the second.
So PWCG is positive.
Yeah.
Okay.
Yeah.
What labs? You said so. CBC, your WBC is 12. Hematocrit 29.8%. Platelet 253. Sodium 139. Potassium 4.2. Bicarb 23. Creatinine 0.8.
Lactate?
4.
Lactate is 4. So, have I got the another cannula in?
Yes, long time ago, doctor. You have
two cannulas in, and then I will start the second liter and blood.
Okay. And the patient is telling you, I'm still in pain.
She's still in pain. For sure, because she's ectopically bleeding. I'm gonna give her, with this blood pressure, 25 mics of fentanyl as well.
Okay.
For more analgesia.
Okay.
And for me, I need to dispose her ASAP. I'm resuscitating the patient at the moment. I'm going to call gynae and ICU.
Okay.
Both.
So,
though, and I have, my hospital does have these facilities, right?
Yes.
Okay.
You have gynae.
Yeah.
Okay.
Okay.
So the gynae comes and tells you, yes, this patient has ectopic pregnancy and she's in shock because she has hemorrhagic shock right now. Okay. Doctor, please give her the RHO immunoglobulin.
Yeah.
Please. Okay.
Yeah.
And then we will take the patient to the OT.
Okay.
We'll prepare for level 1 OT.
Okay.
All right.
So I saved the patient.
Kinda. Okay, Soniya. How do you feel after finishing the case or going through it? Did you do well?
So I was very nervous to begin with. That's why I messed up the numbers of the cannula.
Okay.
And
now she's giving herself some excuses, blaming it on the nervousness and the anxiety.
And the second thing would be, it was a nice case. I really liked going through with it. Something very commonly we see in our practice. And it went well. Otherwise.
Okay. Anything that you could have done better?
I could have obviously put my nerves under control somehow.
Yes.
So that I don't say internal, external for cervical loss.
Okay.
And I think I really got fixated once I heard the history of vaginal bleeding with abdominal pain and LMP 1 month ago, that I should have had wide differentials. But the diagnosis fixation is something I should not do.
Yeah, you should just keep a wider differential and make sure to rule it out, whether it was by history, examination, and your utility, yani whatever labs, let's say ultrasound, all of that, right? That's good. I would like to know what was going through your head. I would like to know what were your differentials at that point.
Since the case started, young female in reproductive age, with abdominal pain, vaginal bleeding. For me, the differential to begin with was a pregnancy. And then obviously when I went into more with the past medical and surgical history, I realized could be ectopic.
Based on what?
Tubal ligation does not mean that it's the best way of contraceptive, to be honest.
Okay. A recent surgery, actually.
Yes.
Tubal ligation is one of the risk factors for ectopic pregnancy,
yes,
right?
Exactly, yeah.
Okay.
So that was my first impression.
Okay.
And again, in this age group, there could be a lot of differentials. However, the way she presented and the initial set of vitals, she was hypotensive to begin with. And she was vaginally bleeding.
Okay. So what could it be also, other than this?
It could be also even sepsis. But then she was afebrile, septic shock for that matter.
So the vaginal bleeding, it could be her menstrual period, right?
Yes.
So you have shock itself.
Yeah.
So from the shock, you need to narrow your differentials, whether to know, is it distributive shock, cardiogenic shock, is it like, obstructive shock, right? Hemorrhagic shock, hypovolemic shock, right?
Yeah.
Then you will narrow it based on the history, examination, and your rush protocol.
Yes.
Ultrasound was, okay?
Yeah.
And other than this, what other differentials it could be? So it's a right lower quadrant pain.
Yeah.
Or hypogastrium also a pain.
Yes.
So what would you think? Like
could
it's
be
a lower
torsion.
abdomen. Yeah.
Could be appendicitis. Could be all the organs there, which are there in the right lower quadrant could be affected.
Interesting, Sonia. Interesting answer for an exam question.
Yeah,
okay.
But from the beginning, I had narrowed it down since based on the patient's presentation, and LMP was 1 month ago. This was the biggest clue in.
Okay, all right. So
the narrowing.
Well done. You got the diagnosis. You managed the patient, but was it an optimal approach and resuscitation? I'll say 65%. I'll give you that. Okay?
Okay.
But this is the time where you will learn, right?
Yes.
Okay? And doing oral boards actually practice will help you even in the clinical, yani. You will have a proper approach when you manage the patients, okay?
Yes.
So, we'll discuss the critical actions and what you have done or what you have missed, okay?
Yes.
So, you mentioned 18 gauge cannula in a shock patient?
I want to say 16.
14 even, bilateral.
Yeah,
both
14,
IV access.
but I was so nervous,
but
which is clearly on my face.
This is ABCD of resuscitation, Sonia. It's fine. So you mentioned IV access. You said 1 initially, then you said the wrong gauge, but then you added another cannula in.
Yes.
But remember to do this from the beginning.
Yes.
Because you need lines, right? She's in shock, whether it's hypovolemic, septic, you need fluid, then you need to replace the volume, or you need to start you find the cause and you try to fix it, right? And treat it. All right. And then we addressed that the patient was in shock a bit late. Then you realized, I need to order blood type and cross match.
Yeah.
Or you
I
can
wanted to
go.
focus because you know how hard it is to keep collecting labs again and again, especially in short patients. So I wanted to have some history and examination before I get
which
my
is
labs.
understandable.
Yeah.
But you said initially you thought it's ectopic from the history and the examination and her vitals, right? So you were expecting ectopic pregnancy and hemorrhagic shock.
Yeah.
So it would be more ideal if you ordered the blood type and cross-match, or if you ask the nurses to get you O negative from the rhesus.
Makes sense.
If it's available in your facility, immediately.
Yeah.
Okay. So you did not mention, I had to prompt as OBGYN to tell you to give the RH immunoglobulin.
Yes.
Okay. This is really important.
Yeah.
Okay. We'll talk about that later on.
Yeah.
You asked for a beta SCG. You did the pelvic examination. You did not do a pelvis ultrasound. You did more of a suprapubic approach as Roche protocol.
Yeah.
But still you got your answer.
Yeah.
Okay. Your pain management, you started right, but you did not escalate until I prompted you to. You need to always reassess your patient.
Yes.
Okay.
Yeah.
I had to say, the patient was still in pain.
Yeah.
What would you do? Okay.
True. Yeah.
All right. And you consulted obstetric and gynecology after kind of diagnosing the patient with ectopic pregnancy for the disposition. Okay.
Yeah.
All right.
Yeah. Wanted to resuscitate the patient in ED and then
which is not wrong. Okay, but it's always better if you call for help from the beginning because until they come, assess the patient, take her to the OT, you have done your resuscitation at that time, right?
True.
Okay. So learning points. So ectopic pregnancies are the leading cause of first trimester pregnancy-related maternal deaths. Okay, the incidence is higher in non-white women and teenagers. Okay, there is an increased incidence in patients with prior sexually transmitted diseases, unsuccessful tubal ligations, assisted reproduction, intrauterine devices, prior ectopic pregnancies, previous pelvic surgeries. Okay. Most ectopic pregnancies occur in the fallopian tubes. Other sites include abdominal cavity, cervix, and ovary. I remember there was a famous case that it was near the liver, an ectopic pregnancy. I don't know if you heard about it. That was weird. Okay. So even now with upper quadrant pain, you need to ectopic pregnancy. Okay. It is critical to administer the RH immunoglobulin. Okay. To RH negative mothers to reduce the maternal antibody formation against fetal hemoglobin. Okay, so this sensitization can lead to neonatal hemolytic anemia and fetal hydrops, as you know. Okay. Also, peritoneal signs are ominous and suggest an obstetrical emergency. Okay, so feedback, right? So you started correctly. You said, how does the patient look like? But then you jumped into history without making sure you did the primary survey for the patient. Remember your ABCDs? Okay. Especially I told you that the patient was hypotensive at that time, right?
Yeah. True.
Okay. So you need to make sure that the patient is stable.
Yes.
First of all. Okay. And then your history. So this case, as a case, has a lot of clues.
Yeah.
Okay.
Yeah.
Her age, she's married, even a non-married, you can consider that. Actually, she had C-section. I didn't want to say that even as a clue. Because I was like, oh my God, there will be so many clues that will lead you to ectopic pregnancy immediately. And you asked about if she's on any contraceptives, if there is any chance of pregnancy. Here, I told you, she had the tubal ligation surgery. You did not ask if this abdominal pain, you were so fixated that this is a gynae emergency. Okay?
Yes.
It could be appendicitis, it could be torsion, it could be so many other things, right?
Yeah.
It could be weirdly cystitis or pyelonephritis with the urosepsis. You never know, right?
True.
So your history was very focused, and your review, you did not do any review of system, by the way. You did not ask me any other symptoms at all about that patient.
Yeah.
Okay?
I was in a impression that I need to resuscitate her without
Understandable.
having vague differentials, which I should consider. Yeah.
So if you did your primary and you started resuscitation, here you will have the chance later on to take history.
Yeah.
Okay? And no matter what the case is, you really need to take a proper history because it will narrow or will guide you on your management, right? You will have a proper diagnosis, or it will narrow your differentials, so you'll have more focused diagnosis for her. Okay. As we mentioned, actions wise, initially it was correct. You asked for IV access, labs. You gave her initially a bolus of normal saline, which is definitely that's something I would do, because until now I don't know what type of shock it was, right? The nurses had to prompt you a bit from moving the patient from the zone to resus, which this decision actually has to come from you as a physician. Okay, imagine if you had a junior nurse who does not have the experience or did not recognize that the patient was in shock, right? Sometimes, even if she is tachycardic, that means that she's decompensating, right? So you should be the one who's more aware and making that decision. Okay. Examination-wise, you did everything correctly. Okay. So the examination, you focused mostly on cardiovascular than abdomen, and you forgot everything else. Just make sure that there is nothing else going on. Okay?
Yes.
Just ask me, and I'll tell you if it's normal or not.
Yeah.
Okay? Later on, so again, the nurse had to prompt you for giving blood, because you said you want to give her a second liter.
Yes.
When you know that she's losing blood, you should replace it with the blood.
Yeah.
Okay? If it was septic, yes, I understand. We'll give the optimal, like 30 ml per kg of normal saline. Then you will start pressors, right?
Yeah.
And for some reason, you asked me about the coagulation. I would like to know why. What are you looking for? What was your question? You said it twice.
Yes. I didn't want the labs to delay. This is I said it twice.
No, but why did you want to check the INR and coagulation profile?
I didn't want her to go I didn't want her to have those, I don't know if I'm gonna say it correct, DIC kind of situation later on.
DIC, it will come if the patient is septic.
Yeah, but even with these things,
does she have low platelet?
No, she didn't. Yeah.
Does she have petechia, purpura, something?
No, since they are drawing the blood, might as well from the beginning, because I didn't know what's happening initially. Yeah?
You asked for it initially, but will it change your management?
No, it will not.
So the initial view of the ultrasound was suprapubic view.
Yes.
Okay. You actually had the uterus empty. There is no pregnancy. You cannot see anything in the uterus.
Okay.
In any line.
Yeah.
But you had free fluid around it, which basically she was bleeding. So you don't have a pregnancy. You cannot see the fetus in the uterus. So there is no intrauterine pregnancy, which will confirm it even more, because the beta ECG was positive.
Yeah, hypoechoic near the uterus is actually
so that's the uterus, and that there is fluid around it. And there is no implantation.
No implantation. No.
Okay. So that was your first picture. Okay, ultrasound image. Okay. So the second, you're looking for free fluid in the abdomen.
Yes.
Either way, right?
Yeah.
So you'll do the right upper and the left upper also.
Yeah.
Where you will check if there is any free fluid.
Yeah.
You'll pick it more in the right upper. Okay?
Yes. Always. Yeah.
Okay. Other than this, as I told you, you should have consulted a bit obstetric earlier. Okay. Because they need to prepare the OT. They need to take her immediately. Okay. Meanwhile, you resuscitate her. Pitfalls in diagnosis. There are a few points that I would like to mention. So the first thing is ruling out ectopic pregnancy based on beta HCG level. So basically, there is no beta HCG level or a series of beta HCG levels at which ectopic can be ruled out. Even though traditional teaching, they used to tell us, beta HCG level less than 1000, you can rule out ectopic. The second learning point, relying on urine beta HCG in early pregnancy, it's unreliable, unfortunately. So you need to do serum beta HCG. And the third learning point, assuming low risk of ectopic pregnancy in a patient with no identifiable risk factors. So the majority of the patients with ectopic pregnancy have no identifiable risk factors actually. such as tubal surgery or known abnormality or previous ectopic, sexual transmitted diseases or PID, or current IUD, or history of infertility and IVF. This case was more obvious that it was ectopic because she had risk factors, but still keep it in mind it can be an ectopic in a patient who has 0 risk factors. Fourth point, assuming low risk of ruptured ectopic pregnancy based on a normal vital signs. And I think this is the hardest thing in realizing that the patient is having ectopic or the patient in shock with a normal vital signs, okay? So you have to always keep in mind that sometimes patients with, even if they have ruptured ectopic, they might present with normal vital signs. And if you do basically ultrasound like Roche, they might have free fluid in the abdomen. So just keep that in mind. The other thing, the last learning point, don't delay like transvaginal ultrasound or pelvis ultrasound to confirm ectopic if the history and the examination is highly suggestive of ectopic pregnancy.
And that wraps up our oral board case discussion on ectopic pregnancy. We hope it challenged your critical thinking and gave you some useful insights into ectopic pregnancy and the challenges in its management. Hopefully you learned something new. If you found this helpful, be sure to subscribe and share it with your colleagues. We'll be bringing you more cases, discussions, and expert perspectives, all centered around core EM concepts on a monthly basis, inshallah. Thanks for listening, and we'll see you next time on ECREM Talks.